The cases that we are going to present are the combination of CT and X-ray. Some of the cases will have the clinical findings, and we are going to emphasize the importance of the differential diagnosis so that you are able to provide this differential diagnosis whenever you are confronted by a case that needs the differential diagnosis. Then this is the first case of a female patient, 70 years old, with shortness of breath, and she is a smoker. Then you may answer on the chat, where I will comment on your answers. Yes, the answer is right, and this is a classic appearance of a bronchogenic carcinoma at the central type. And you got the mass which is superimposed on the right hilum, and the classic S sign of golden corresponding to the collapsed upper lobe because of the compromise of its bronchus. And this is what do we mean by the S sign of golden. Sometimes you are asked about the appearance of a bronchogenic carcinoma in the plain film, and you may ask it about if a patient had a bronchogenic carcinoma, what do you expect to see in the plain X-ray? And these are the findings. Number one is a peripheral nodule with a speculated margin, or enlarged dense hilar shadow, or pulmonary mass of whatever edge and whatever density. It should be solid, of course, whether it contains calcium or not. Or you got a central lesion with ipsilateral diaphragmatic elevation due to phrenic nerve paralysis, and the consolidation collapse due to bronchial obstruction, malignant pleural effusion, and the S sign of gold. This is the second case, is for a male patient, 34 years old, with cough, fever, and chest pain. And I provide some of the differential diagnoses for this case, and you can select one of them. Yes, and the answer is pneumonia and effusion, okay? And this is the lateral X-ray of the same case. In the frontal X-ray, and you can see obliteration of the costophrenic angle with some what looks like air fluid level and opacity in the remaining part of the lung. In the lateral view, you got the same air fluid level and the opacity in the lung. And actually, this is the most likely provisional diagnosis from the plain film. But whenever you have the CT scan, and you may change your opinion. Oh, still you are. Um, I don't know what you mean by 5. You mean the fifth answer? If you mean so, and this is right. Emphysema and pneumonia, this is right, because you got an insisted collection underneath the lung. The lung is almost subtotally collapsed, and you got some consolidation in the upper lobe, and the margin of the collection is enhancing, and also you can see some small air loculi, and the diagnosis is emphysema and pneumonia. This is the difference between emboyema and lung abscess. The lung abscess is rounded, and emboyema will follow the course of the pleura. Emboyema will have the split pleura sign, while the abscess is not. The angle between the abscess and the pleural surface is acute, while the angle between the pleural surface and the emboyema is obtuse. Emboyema is an extrapulmonary lesion which will be associated by collapse of the underlying lung, while the abscess is not. Then this is the next case where you got a patient 55 years old with cough and progressive dyspnea, large amounts of mucus or sputum were expelled during major cough attack. Bronchoscopy showed normal major bronchi. Then bronchoalveolar lavage was negative for malignancy. Then your answers are in the direction of metastasis, and this is right because I always emphasize the diagnosis of multiple pulmonary nodules or masses are in the direction of metastatic deposits. But then actually this is the follow-up of the patient after 4 months. Then I provide this differential diagnosis. Is it TB or is still prefer the diagnosis of metastasis or pneumoconiosis or sarcoidosis or alveolar cell carcinoma? Yes, you still see that metastasis is the most likely diagnosis, but you remember that I have mentioned before that alveolar cell carcinoma may start as nodules in the lung, minute nodules or miliary nodules, then they coalesce together to form large nodules, then larger nodules will coalesce together to form batches, and you still see in the lung some of the nodules, and this is one of the diagnostic landmarks of alveolar cell carcinoma. Then whenever you are confronted by an appearance like this, which include a consolidation, and in the same lung or in the opposite lung you get some of the nodules, these nodules are the precursor of this consolidation and this one. And this is the one of the signs that help you to predict the possibility of bronchoalveolar lavage. Then you will ask why the bronchoalveolar lavage is negative for malignancy, and this is a frequent finding in bronchoalveolar carcinoma. You got copious sputum or watery like sputum, which is difficult to detect malignant cells in the lavage. Then and even also in metastatic deposits,
Recording stopped.
you will not see some malignant cells in the bronchoalveolar lavage. Then the diagnosis is bronchoalveolar carcinoma. Bronchoalveolar carcinoma represents about 10% of primary lung cancer, and this is the presentation. Bronchorrhea means a lot of watery sputum, and the CT angiogram sign, which I emphasize, it is not specific. You see the vessels on the background of the consolidated lung, and this sign will also be seen in some cases of pneumonia, lymphoma, and sometimes pulmonary edema. One of the pathognomonic findings for bronchoalveolar carcinoma is to see a mass or nodule with air bronchogram, and this will have these three differential diagnoses, which include round pneumonia, which is common in the pediatric age group, pulmonary lymphoma, and bronchoalveolar carcinoma. And Many times we need to have a biopsy to confirm the diagnosis, but whenever you are asked to select one of these two conditions, bronchoalveolar carcinoma
Recording in progress.
is relatively common more than the lymphoma. Then we have a male patient, 85 years old, with a chest X-ray to assess uh, uh, the progression of pneumonia and to confirm the position of the nasogastric tube. Then here you can see the nasogastric tube is okay. It's located inside the gastric lumen. But in the lung, what do you think? Yes, and this is reticulonodular opacities, which are considered in most of the cases because of the presence of nasogastric tube are due to aspiration pneumonia. You know that even in the presence of a nasogastric tube, the patient is prone to develop aspiration pneumonia. And if you see such reticular opacities, especially in the right lung or in the base of the right lung, you should consider this possibility. Then we have this case of a male patient, 61 years old, with chronic myelogenous leukemia and recent onset of fatigue and the cough. And I may give you some of the diagnostic possibilities. Here are the diagnostic possibilities. This is TB or leukemic infiltrations or pneumonic consolidation, alveolar edema, alveolar cell carcinoma, alveolar proteinosis. Number three is, you mean this is pneumonic consolidation or alveolar, another answer, alveolar edema or alveolar cell carcinoma. Okay, this is, of course, is not a pneumonic consolidation because of its central location. Number two, it's not alveolar edema because the heart is normal. And this is not TB because the position or the site of the lesions are not that for TB. Then we are left by alveolar cell carcinoma and alveolar proteinosis, and we need the help of CT. Then whenever you see this appearance, which is typical of proteinosis, the crazy bathing pattern, then you are right to diagnose proteinosis. Actually, I said many times that you cannot predict the diagnosis of alveolar proteinosis from the plain film because of the similarity to almost all cases of alveolar pattern of diffuse lung disease except the pneumonic consolidation. It can be alveolar edema, it can be alveolar hemorrhage, it can be bronchoalveolar carcinoma, and can be alveolar proteinosis. Then this is alveolar proteinosis, and alveolar proteinosis is diagnosed by this very characteristic pattern, which is known as the crazy bathing pattern. And this crazy bathing pattern is not pathognomonic for alveolar proteinosis. It can occur in many other types of pneumonic consolidations as well as alveolar cell carcinoma, interstitial, non-specific interstitial pneumonia, and so on. But if you go through the literature, then you will see every case with crazy bathing is related to alveolar proteinosis, meaning that this is one or the only, or let us say, the most common lesion to give this pattern of consolidation. Then in this case, we have pleural effusion on the right side, and I gave you some of the differential diagnoses: massive effusion, empyema with debris, or mesothelioma with effusion, or pleural deposits with effusion, or lymphoma with deposits. Then actually, for the diagnosis of mesothelioma is the most common primary malignant tumor of the pleura. But you can remember that mesothelioma is a sheet of soft tissue, non-uniform thickness soft tissue masses encasing the lung and extending into the fissure. Of course, mesothelioma can present by focal masses like this, but I think if you see focal masses like this, it's better to predict the possibility of metastasis rather than the possibility of mesothelioma. Then whenever at what time you will say that this is lymphoma if you see any stigmata of the lymphoma in the film or in the clinical practice. Then we have a female patient, 34 years old. She is intravenous drug abuser, admitted with fever for 10 days, dyspnea, tachycardia, and fever. Okay. Then these are the uh, possibilities: TB, metastasis, septic emboli, sarcoid, alveolar, rheumatoid, Wagner. Of course, the history is very classic and pathognomonic, and your answers are actually right, and these are septic emboli. The septic emboli are solid whenever they are small, and they cavitate when they are relatively larger in size. The history is very important to predict the possibility of septic emboli. You know, one of the most common causes is endocarditis, bacterial endocarditis, and drug addiction. This is one of the leading factors in the history to predict this appearance. But whenever you are not provided by the clinical data, and at that time you give the differential diagnosis of multiple cystic like pulmonary nodules, or cavitating pulmonary nodules. The differential diagnosis will include, of course, metastatic deposits, septic emboli, Wagner granulomatosis, uh, um, rheumatoid nodules, for example. All these nodules can cavitate. Then bilateral nodules they often cavitate whenever they are slightly larger, and lesions are more numerous in the lung bases because of the circulation towards the bases of the lung are of course much more than those towards the ABCs, and the feeding vessel sign, similar to any embolic material like metastasis or pulmonary embolism, they are go through the vessels. Then we have this case with progressive dyspnea but no fever. TB, yes. These are some of the differential diagnoses: TB, fibrosis, post-TB, pneumoconiosis, sarcoidosis, histiocytosis, and the answer is TB. But from the plain film, actually, and this is the CT scan of the same case. Then you can see in the CT scan that there are masses with dense calcification, and he also got some calcified mediastinal lymph nodes. Then this is of course the progressive massive fibrosis of pneumoconiosis. You got two big masses on either side of the upper part of the mediastinum, and you may see some of the pulmonary nodules scattered everywhere. And this is, of course, it is not that evident in the plain film. And whenever, if you say from the plain film only that this is TB, you are right. Then after the CT, you should change your opinion to the progressive massive fibrosis. This patient had cough and fever. Yes, and this is pneumonia. I intended to provide this case because you know that all patients are extremely oriented by COVID. And many of the cases diagnosed as COVID are not actually COVID. They are pneumonic consolidations due to any other organism. And you know that I emphasized the RSNA guidelines for the diagnosis of COVID infection, and this should not be mistaken for any other forms of pneumonia or other forms of diffuse lung disease. This was confirmed to be simple staphylococcal pneumonia. Then this patient is asymptomatic, and she had a big mass located posteriorly, and these are the differential diagnoses: hydatid cyst, bronchogenic metastatic deposit, schwannoma, esophageal duplication cyst. Hydatid cyst, oh, okay, and sometimes you have the right to say that this is hydatid cyst because you feel that this lesion is cystic. But actually, you know that the schwannomas are usually towards the density of cystic rather than the density of solid. And frequently, we introduce a fine needle to aspirate fluid from these lesions, but we fail. Then we introduce the core, the true cut needle, and we got a core biopsy. Then this lesion is located, of course, in the posterior mediastinum, and there is difficulties to separate the posterior mediastinal lesions from pulmonary masses many times, and there is some overlap between both. Then because of the very smooth edge of the lesion, you may assume that this is benign. And because of this density, you may feel that is hydatid cyst, but please consider the possibility of a schwannoma, because the schwannoma looks many times to be as if it is cystic. This patient with leukemia and stem cell transplantation and prolonged time spent on ventilator. Now he has dyspnea worse with exertion. Anterior mediastinal mass, and actually we cannot say that because the window is not tracheal stenosis. Yes, the answer is tracheomalacia. Yes, this is right. Tracheomalacia, because you see the trachea is a little bit of good lumen, but it's not rounded as we used to see. And at that time, maybe during expiration, and you got almost total obliteration of the tracheal lumen, and this is diagnostic of tracheomalacia. In diagnosed tracheal stenosis if it persists very narrow in all the sections. When it change its caliber, then you think of tracheomalacia. Then this patient is 57 years old, and he was subjected to a blunt abdominal trauma several years ago in a motor vehicle accident. Now complaining of progressive non-radiating abdominal pain in the left upper quadrant, with vomiting and constipation for the last week. Then the chest X-ray showed some opacity in the left hemithorax with multiple air fluid levels. Yes, very good. And this is hernia. Because of the history of blunt trauma, you expected that there is some form of diaphragmatic rupture. And consequently, there should be some displacement of the abdominal organs inside the thorax, and this was confirmed by the administration of some of the oral contrast material. Then this case, this male is 66 years old with a chest X-ray like this, and this chest X-ray was obtained 12 hours later based on deterioration of the respiratory, or let's say the progression of breathlessness. And no, if you look carefully, you will see that the endotracheal tube is well above the carina, and you are right to think of displacement of the tube, but if you look also carefully, you see that the tube is pointing towards the left lung, which is collapsed or opacified. This is right, it's complete collapse, and whenever this collapse occurs in hours and resolves in hours also, you consider mucus plug. And this is important in intensive care patients, and you got some mucus plugging of one of the main stem bronchi, and this will result in collapse, and this will resolve after resolution of the plug. Then this patient had a chronic chest complaint with dysphagia. Yes. How can you, and Hoda, how can you predict that this is scleroderma from the plain film? The answer is right, but for me, it's very difficult to suspect the possibility of scleroderma from the plain film, even if the patient had dysphagia. But from the CT scanning, you got the marked dilatation of the esophagus, which is atonic, as well as the changes of pulmonary fibrosis, which is associated usually with these disorders, connective tissue disorders. And this is, the diagnosis is right, scleroderma with interstitial lung fibrosis. This patient, 23 years old, with severe right shoulder pain, and you got a big opacity in the right upper lobe. Is it hydatid cyst or bronchogenic carcinoma or metastatic deposit or schwannoma or consolidation? Okay. Bronchogenic carcinoma, you should look carefully for the ribs, and this is very important. If you see some of the rib erosions or destructions, you may think so. And according to the rules I have given in the lectures, if you see a mass in an adult, you think of a bronchogenic carcinoma until proved otherwise. And this needs the verification by CT. And this is the CT scan of this case. And of course, as you said, this is the classic appearance of hydatid cyst with a big lesion with internal daughter cysts, but you cannot reach this diagnosis from the plain film, of course. And the right answer for the plain film only is the bronchogenic carcinoma. Then this patient is a female patient, 62 years old with cough and dyspnea. And these are the possibilities. Fibrosis, interstitial edema, lymphangitis, carcinomatosa, bronchoalveolar carcinoma, hemorrhage, and thoracic sarcoid. Very good. Sarcoid is the right answer. This is not fibrosis because fibrosis usually involves the basis of the lung, not the upper or the middle lung zones. And sarcoid on the opposite side will involve the upper and middle lung zones, and at a later stage of sarcoid, when it goes into fibrosis, it will form what looks like interstitial lung fibrosis, but it does not affect the lung basis because this is not the distribution of sarcoid. And the answer of sarcoid is very good because the changes are somewhat away from the lung basis. And these are the stages of sarcoid. Stage 1 with lymph nodes only, stage 2 with lymph nodes and reticular opacities, or reticular opacities with nodules, or lymph nodes, reticular opacities, and nodules, and the final stage of irreversible fibrosis, which is exactly similar to idiopathic pulmonary fibrosis or usual interstitial pneumonia. This patient had this mass in the upper part of the right hemithorax, and this is the CT scan of the same case. Then here some of the possibilities: bronchogenic carcinoma, bronchogenic cyst, cystic schwannoma, lung abscess, hydatid cyst, TB lymphadenopathy. Bronchogenic carcinoma, no. Abscess, no. Bronchogenic cyst is right. Then the bronchogenic cyst is right because this is a mediastinal pathology and is not a pulmonary pathology. Number one, this lesion cannot represent a bronchogenic carcinoma. It is almost totally cystic with a relatively thick enhancing margin. If this is an abscess, it should not extend inside the mediastinum. And I emphasize this fact many times. A pulmonary lesion cannot insinuate itself within the mediastinal structures, below the superior vena cava, pushing the trachea, and so on. But the mediastinal lesion will show these findings. Then this is not hydatid cyst and is not a lung abscess and is not a cystic schwannoma. It is not a posterior mediastinal lesion. it's not a bronchogenic carcinoma because it is a mediastinal pathology, then this possibility is good. And also TB lymphadenopathy, you know, this should be multiple, and they are usually adherent to each other, and they are not usually show a single necrotic mass. This is a bronchogenic cyst. Then this case is provided to show the some of the lesions in the mediastinum, in the lung, and in the interstitium. Pulmonary embolism. This is lymph node, and this is also lymph node. Then I usually emphasize this appearance not to be mistaken for pulmonary embolism, especially on the right side. Then sarcoid, maybe because this reticular opacities in the lung are in the lymphatic distribution. They are typical. And TB, I don't think so because the nodes are not necrotic. If you know that the patient had renal cell carcinoma, then your diagnosis should be lymphangitis carcinomatosa with metastatic lymphadenopathy in the mediastinum, bilateral pleural effusion more on the left side. Then this patient had a breast cancer. This is chest X-ray, AB and lateral. Very good. Yes, the answer is right, and this is sclerotic deposits, and this case is provided to you to let you know. Don't concentrate if you are reviewing chest cases. Don't concentrate only in the lung and the heart and mediastinum, but look also to the skeleton. The chest may be absolutely normal, but the skeleton is not, and these are metastatic sclerotic deposits. This patient had the massive left-sided pleural effusion. And you know, massive pleural effusion has a list of the differential diagnosis, and I give you this list. Then you got post-cabbage and malignant effusion if the primary is present in the lung, the breast, the lymphoma, and others. And there are a very long history. Actually, I said many times that massive effusion should raise the possibility of an underlying malignancy. And this malignancy may be in the pleura, in the chest wall, in the lung, or in the mediastinum. And in these cases, CT is mandatory to see what's going on in the region of the effusion. Then this is CT. What do you think? Yes, and this is metastasis. Very, very good. These are metastatic deposits. You got a mass in the pleura and some masses here. This is not mesothelioma. I say many times, mesothelioma is a sheet of pleural thickening, non-uniform, almost totally encasing the lung. Of course, focal mesothelioma can occur, but it is, I can say, relatively, or I would not say extremely uncommon, but it is relatively rare compared to the diffuse type of mesothelioma. This patient with chest X-ray and a mass on the left side, and these are the differential diagnosis. Bronchogenic carcinoma, aortic aneurysm, lung deposit, lymphoma, teratodermoid cyst, TB lymphadenopathy, invasive thymoma. Invasive thymoma TB 1, 2, 3, 4, 5. Teratodermoid cyst. I think this is the right answer, but I don't know how can you predict from the plain film. Yeah. Also the possibility of lymphoma maybe, but I encourage you to diagnose bronchogenic carcinoma, which is the common pulmonary lesion. But if you feel that this lesion is not a lung pathology, and Sarah is putting some of the right answer, that this is not a lung mass, it's a mediastinal mass, because in the lateral view it's projected anteriorly. Then if you are going to diagnose anterior mediastinal mass, then you think of thyroid, thymus, teratodermoid, and the terrible lymphoma. And you need, of course, the CT scan to solve this problem. And here is the CT scan, and you got a mass with chest wall deposit. And do you change your diagnosis or? Yeah, and you still suspected the lymphoma, and this was proved by pathology to be a bronchogenic carcinoma. I, uh, I, uh, I have been confronted by a mass to have a biopsy from it. The mass is exactly centered in the mediastinum, encasing the vessels, and I got the biopsy, and I was convinced that it should be a lymphoma, and it happened to be a bronchogenic carcinoma. Then this is the chest X-ray, and you see diffuse lung disease. And whenever you see a chest like this, then you will ask about the history. Sometimes they may not give you some conclusive history. Then you have to describe the appearance, and you suspect one of the diffuse patterns of lung disease. Yes, the diaphragm is flattened somewhat, but you got diffuse abnormality in the lung. Let us say if we have, yes, and I provide this differential diagnosis: pneumomediastinum, acute respiratory distress syndrome, cardiogenic pulmonary edema, COVID, chronic bronchitis, acute eosinophilic pneumonia, and miliary TB. ARDS, and this patient is known to be HIV positive. Then the answer will be why not COVID? Yes, the answer will be this type of pneumonia, pneumocystis pneumonia, Also, sometimes you got, because of the immune compromise of the patient, why this lesion is not a COVID. Actually, we cannot diagnose COVID for sure from the plain film. But sometimes, and because of the pandemic, we assume that the changes in the lung may be related to COVID. Then we will have the CT scan to confirm the distribution of the opacities and to reach the diagnosis. Then this is not miliary TB because these are alveolar lesions. They are not miliary opacities. This patient had a history of chest trauma. Yes, lung contusion is very good, and this is the right diagnosis, of course. Even if you do not see any rib fractures, you should diagnose these contusions. But if you are confronted by a CT scan like this, and you have no history, or you do not know that the patient is subjected to trauma, you cannot say that these are contusions. Many times in the exams, they provide cases like this where you can notice a small rib fracture on the right or in the left. And they will not give you the history because the history is seen in the film. And if you are um, let us say intelligent enough, then you will see the rib fracture and you say that these are pulmonary contusions. Then this male patient, 67 years old, presented by acute chest pain and hemoptysis. This is the plain film of the patient, and this is the CT scan where you got some opacity here in the left lower lobe. Yes, right. This is pulmonary embolism because of the history, acute chest pain and hemoptysis. And this is the CT pulmonary angiogram. And you got a filling defect here and a linear filling defect there with the pulmonary infarction in the right lung base. The diagnosis is right. This is pulmonary embolism. This patient, 83 years old, that became paraplegic after a car accident. This is the chest x-ray and this is the CT scan of her chest. I think we have some of the differential diagnoses, but you should consider the history of trauma. This is very important. Um, if the aorta is ruptured, I think that the patient will die at the scene of accident. But you see, this is the CT scan, and these are the possibilities: lymphoma, leaking aneurysm, infected bronchogenic cyst, esophageal cancer, TB, spondylitis, peri-aortic hematoma. And this is the right answer, where you got fracture of the spine and a big posterior mediastinal hemorrhage surrounding the aorta. If the aorta is ruptured, you got some of the contrast material also leaking within the hematoma, and this is a catastrophic event, of course. But this hematoma, I think, is coming from the spine, not from the aorta itself. Yes, dorsal compression fracture with posterior mediastinal hematoma. Then this is a spot diagnosis case. This patient is candidate for coronary bypass surgery, and he presented by chest pain and the CT scan showed this lesion. This is not, of course, a cyst. No, it's not a cyst. Thrombus dermoid, no, it's not dermoid. And then the thrombus within the heart, you mean? No, this is outside the heart, right ventricle, right atrium, right ventricle, left atrium. Cardiac tumor, no. This is the classic appearance of an aneurysm. You may heard me many times saying that a rounded black lesion with a central white lesion is diagnostic of an aneurysm. And this is an aneurysm of one of the coronary vessels. Okay. This is the chest x-ray, and you got some opacity on the left side together with obliteration of the left costophrenic angle. What do you think? I think we have some of the differential diagnosis. Effusion, pneumonia and effusion, infarction and effusion, rib fracture and contusion, chest wall mass and effusion. Pneumonia and effusion, pneumonia and effusion. Yes, this should be the right answer from the plain film, but this is the CT scan of the same case, and these are some of the possibilities. Rhabdomyosarcoma, no. Chondrosarcoma, no. Chondrosarcoma, no. Mets, yes. I also said in the lecture of chest wall and pleural that if you see a mass centered on the chest wall, meaning that the part of the mass is inside the hemithorax and other part is outside the hemithorax associated with destruction of the rib, you think first of all for metastatic lesion. Then and the association of pleural effusion is can fit for all these possibilities. This is not mesothelioma, and the chondrosarcoma, the lesion does not contain matrix calcification, and this is just destruction of the rib. And the first possibility should be metastasis. Then, this patient is a healthy asymptomatic female with a chest radiograph taken as a part of routine checkup. Then you got a lesion here, and these are the possibilities. Hydatid, bronchogenic, lymphoma, aortic aneurysm, bronchogenic cyst, teratodermoid cyst. Aneurysm, no. If you see the contour of the aorta, you can exclude that this lesion is originating from the aorta. Then any of the mediastinal masses can fit for this, and you need the help of CT scan. And this is the CT scan. Bronchogenic cyst. Yes. Teratodermoid cyst, and this is the right answer. If you look carefully, and you can see fluid in this lesion with faint matrix calcification. You know that there are three requirements for the diagnosis of teratodermoid cyst: fat, calcium, and fluid. And you may got two only of these, but fat is very important actually. And this is not the site of bronchogenic cyst, as you know. The bronchogenic cyst is usually located at the level of the carina, and this was a teratodermoid or a mature cystic teratoma. This is a female patient, 83 years old, with a stroke. And the chest X-ray, this is the chest X-ray on admission, and this is the chest X-ray 1 day after deterioration of the or increase in the dyspnea. No, this is not ARDS and not a hemorrhage. You should consider this condition, the stroke. Aspiration, yes, this is right. Aspiration pneumonia. If the patient is unconscious, then the liability for aspiration is very high. And if you see this rapid change in the chest, then you consider aspiration, and the aspiration is the right answer. Aspiration commonly occur in the right lung, and in the supine position, it involves the posterior segments. If the patient is erect, it will favor the right, middle, and lower lobes. Then this is the only case I think of is MRI, and you got a lesion, and this lesion, as you can see, is a cystic lesion, and it shows low signal in the T1, high signal in the T2, and these are the possibilities. Lipoma, bronchogenic cyst, esophageal duplication, thymic, esophageal diverticulum, and meningocele. It's not a meningocele, not an esophageal diverticulum. It is a cyst, and this site is suitable for the diagnosis of thymic cyst. Okay, this patient is 35 years old. He has many calcified lesions in both lung fields. What do you think? TB, and this is not miliary TB, and these are not tuberculosis, and this is not the distribution of TB in general. Silicosis, and these are the possibilities. Calcified metastases, multiple tuberculomas, multiple hamartomas, healed sarcoid, foreign bodies. Mets, yes, this is good. The multiplicity is in favor for Mets, whatever they are cystic or they are calcified, because you know that some of the metastases can be calcified, like those coming from mucinous adenocarcinoma of the colon, and those coming from osteogenic sarcoma and chondrosarcoma, for example. Okay, this patient, female, 67 years old, and this is the chest X-ray, and this is the follow-up 2.5 months later. Um, Very good, actually, Sarah. This is very good answer, actually. Um, uh, if you look carefully for the first film, and you will diagnose pneumonia. And at that time, between this film and this one, you may predict that the patient received a lot of antibiotics without improvement and even progression. Then you know that you are dealing with another type of pneumonia, which is the cryptogenic organizing pneumonia. Very good, the answer, actually. Okay, what do you think of this? The section, yes, this is the section, and it is dissecting aortic aneurysm. And No, this is not pneumopercardium. This is air embolism. You know that because of the use of the automatic injectors, sometimes the air is not actually emptied from the syringe. Then you inject air with the contrast material. It will accumulate in the pulmonary artery, and if it reaches a sizable, a good size, it may affect the patient life. Then this patient with cancer bladder, pneumothorax, no. Hydropneumothorax, yes. And Mets, yes. You got nodules in the lung. These are metastatic deposits. You got hydropneumothorax as well, and this is the right answer. Hydropneumothorax and lung metastasis. Thank you very much.